emerging concepts in hypertension, paving the way for improved outcomes. And Dr. Venkata S Ram will be the panelist and the expert. Dr. Venkata S Ram, as we know, Padma Dr. Venkatram is Director, Apollo Institute for Blood Pressure Management and Director, Blood Pressure Clinics, Apollo Group of Hospitals, Hyderabad, India, Dallas, USA, and Sydney, Australia. He is Vice President, American Society of Hypertension, past Chairman, Board of Governors, American Society of Hypertension, pioneer work in hypertension, and unique skilled communicator of scientific advances. He is rated as one of the topmost doctor in the world of high blood pressure treatment, and he has more than 300 publications and a book on hypertension, and he's on the editorial board of numerous national and international journals, and he's the youngest person ever to become Master of American College of Physicians. So, Dr. Ram, the definition of hypertension keeps on varying with various guidelines. ESC 140 by 90, ACC 130 by 80, ISH 130 by 85. Why there is so much confusion, and what is the solution for these different guidelines? And do you have some new definition of hypertension? So what should be the cutoff point for diagnosing hypertension?
Yeah, PC, first of all, let me thank you for asking me to participate in this discussion. As always, it is a pleasure to participate in any medical education conferences that you organize, because you bring a academic perspective to the clinician, which is so important, that you bring a high quality of science. And the preceding speaker, our good friend, Prakash, is such an example that you bring people who know the subject. Couple of things I want to comment on what Prakash said. Ladies and gentlemen, kidney is the heart of the matter of cardiovascular disease. He has mentioned, he almost talked as if he's a nephrologist, not a cardiologist. He mentioned so many times about GFR and kidney function. So ladies and gentlemen, don't ignore those creatinines of 1.4, 1.5 until they become 5. Then they don't need a doctor. They need a dialysis technician. So ladies and gentlemen, pay attention to early stages of CKD and prevent the progression to end-stage renal disease. Now, coming back to Dr. Manoria's comment, is the blood pressure definition changed since 2017 for a reason, because both observational data and limited therapeutic data have consistently shown that any blood pressure that is greater than 130 over 90 over 80 for a period of time can cause significant cardiovascular damage. So if a blood pressure that is higher than 130 by 80 over a period of time, there is what is known as a multiplier effect, where the blood pressure keeps going, and causes significant cardiovascular damage, left ventricular failure, heart failure, CAD, atherosclerosis, carotid artery stenosis, you name it, CKD importantly. So the blood pressure, let us say, I'll give you an example, PC. Let us say if somebody has a blood pressure of 136 over 84. Over a period of time, this 136 by 84 does not stay 136 by 84. It becomes 138 by 88. It becomes 142 by 92. It happens very, very progressively, like a metastatic disease. And a number of analyses now have shown, even people who criticize the new guidelines, that the public health is best preserved if the blood pressure is less than 130 or 80. So I don't think there is much controversy now, PC, as it was 2 years ago. The definition of hypertension according to ACC American Heart is 130 by 80. The definition of European Society of Cardiology, European Society of Hypertension is 140 by 90. And the definition of hypertension according to International Society of Hypertension is 135 by 85. So you are correct. There are three definitions, but they all have a common denominator. All of them recommend the goal blood pressure of 130 by 80. So it does not matter which guidelines you want to follow, Indian guidelines, European, American, it does not matter. They all lead to the final pathway of blood pressure less than 130 or 80, except International Society of Hypertension in their guidelines 3 months ago have suggested for elderly patients blood pressure between 130 to 140, 80 to 90 is acceptable. And by the way, I agree with that. I think for the elderly that is reasonable. But I think in general, there is a consensus a blood pressure greater than 130 by 80 over the long term is going to cause significant morbidity and mortality. So this is what is called now new normal blood pressure.
The blood pressure can be measured in the office or at home by the home blood pressure monitoring or by ambulatory blood pressure monitoring. So somebody wants to know what strategy should he employ for diagnosis of hypertension, or a combined strategy should be employed.
Okay. I will give you a twofold answer. As a clinician, as somebody in the clinic, I would now suggest that the best way to get the blood pressure is an automated device in the office. Office blood pressure measurement, OBPM, with an automated device. And there are many good automated devices which take average of 2 or 3. And that is probably the best way to measure the blood pressure. Don't worry about the machine. There is always a tendency when the blood pressure is high to blame the machine. But when the blood pressure is normal, nobody blames the machine. And that is the problem with blood pressure, unlike glycated hemoglobin. So I can openly tell the attendees that all the devices that you have for blood pressure measurement, automated devices that make 2 or 3 times, they're quite accurate and they should be used in the office. Even if the patient is sitting in front of you, I would use it because it removes the error. That is the best way to do it. Now, as an academician, as a people who write academic papers, they would suggest taking into account home blood pressure measurement in the diagnosis, and that is impossible. Hypertension is very common. It is not like mesothelioma. It is not like asbestosis. So when a condition that is so common, I don't think we should make it so complicated. Home blood pressure measurement is very, very fashionable to talk about because nobody can oppose it. Nobody can oppose home blood pressure measurement. It is very fashionable. It is the in thing. But we do not know the standardization of home blood pressure measurement, sitting position, standing position, when it should be taken. Should it be taken within 3 hours after a meal? Because after taking a meal, the blood pressure falls. And the other thing, most important thing that doctors don't like to talk about in public forum is if a patient calls you saying that my home blood pressure is 150 by 100, are you going to start the treatment? Or if a patient calls you saying that Dr. Manoria, my blood pressure is 110 by 70, are you going to stop the treatment? No, the answer is no to both. So home BP, unless it is further standardized, where there is objective reliability of accuracy, how it is taken, it will continue to be discussed, but it won't be the basis for the treatment. Now, the ambulatory blood pressure measurement, on the other hand, has a greater promise than home BP. The difficulty with ambulatory blood pressure measurement is not many doctors have it, and not many hospitals have it. And now most of the hospitals use, or the doctors use, with a cuff. And that is very, very difficult because when the cuff inflates in the night, there is what is known as cuff-related increase in blood pressure. So the compression of the cuff increases the blood pressure, even during the night time. So my suggestion would be if possible, try to use, if it is available, so-called cuffless BP, if it is available. I know that in many places it is not available, but believe it or not, of all the countries where cuffless BP is more readily available is India. And I say it from experience. I wanted 4 cuffless ABPMs 3-4 months back. They were there within 48 hours and they are very, very reliable. So my suggestion would be ABPM does have a place, but I am not a big respecter of so-called cuff ABPM because people don't sleep. If you can get hold of so-called cuffless ABPM, which uses applanation tonometry and estimate the BP, that is reasonable. And one more thing I want to mention. Studies have shown that the correlation coefficient between aortic blood pressure and cuffless ABPM is close to 0.9 or 1. So you don't have to question the technology. I know that for some reason, something that you want to do is prevented and you blame the technology. Machine is not good. Cuffless BP is not good. We don't have, you need to have evidence for that. So PC, my suggestion would be automated office BP, followed if possible the ABPM, and home BP, how much value you want to put becomes highly individualistic, and it is not regulated.
The other common issue from the physician side is we have systolic blood pressure, we have diastolic blood pressure, we have pulse pressure, we have mean blood pressure. What is the importance of each and does it vary with age? What are your comments?
Of course, you know the answer, PC. The pulse pressure is, of course, a measure of the resistance and systole and diastole. Pulse pressure is a parameter of cardiovascular homeostasis and cardiovascular health. And in fact, there was a moment when people from the Framingham study who analyzed it, such as Dr. Franklin, has said that maybe one should use pulse pressure as a target for treatment. But the problem is, as it is, we are not using systolic blood pressure properly. As it is, we are not using diastolic blood pressure properly. What is the point in bringing one more parameter which is less likely to be used? So now both systolic and diastolic blood pressure are important. As you know, in the Indian subcontinent, more studies are coming out with isolated diastolic hypertension in people between the ages of 20 and 40. People have 116/94, 120/100. By the way, I can attest to it. I have seen it. It is not uncommon. So both systolic hypertension and diastolic hypertension are important. I don't think we have the luxury of separating systolic and diastolic hypertension. But if you ask me, what is a single blood pressure if you have to take, if you are forced to take only one, what would you take? I would say systolic blood pressure. Both are important, but systolic blood pressure is a very strong predictor of cardiovascular mortality also.
All of us know central aortic pressure is a better predictor of cardiovascular events in future. So do you think this technology will come to the clinics in future or it will remain a research tool?
Obviously I have to separate my own personal interest and bias from what is applicable. The central aortic blood pressure measurement now is not complicated the way it was until 5 years ago. Now, with technology developed by different companies, central aortic BP is measurable, it is reliable, and clearly it is a better marker of cardiovascular health. Public health point of view, the strong heart study in US has shown that it is the best predictor of cardiovascular morbidity and mortality. But no trial has looked at the outcome of altering the central aortic blood pressure. Small sub-study of ASCOT has shown the therapy that reduced central aortic BP appears to be better than the therapy that did not reduce central aortic BP. Smaller sub-study. Larger studies have not been done. So I do believe the central aortic BP is very sensitive marker of cardiovascular health and prognosis, and it should be utilized on an individual basis, but no guidelines do recommend it because every guideline committee is worried that we are not measuring the usual BP properly. How can we advance this to a more difficult one? No, it's not difficult. How do you want to advance it to a different level? So at least my personal hope is that central aortic BP should be used more and more, despite the absence of prospective studies, and it could be a good target for the treatment, and especially combination therapy.
Currently, the focus of attention in all cardiometabolic diseases is shifting from father to son. We have isolated systolic hypertension in young, childhood diabetes, young infarcts. So what are your comments on isolated systolic hypertension in the young? What is its pathogenesis and what is the treatment for it?
Isolated systolic hypertension in the young, defining, let us say, not very young, because obviously if it is very young, like pediatric, irrespective of the level, I mean, systolic, they need a workup. If somebody has an isolated systolic hypertension in the younger age group, let us say 25, 35, isolated systolic hypertension repeatedly, 150 by 60, 148 by 50, etc. Obviously, this is the reason why I'm not a big fan of telemedicine. You have to listen to the patient's heart to make sure that the patient does not have aortic regurgitation, either by clinical exam or by echo. And in people who have unexplained bone diseases, you want to make sure they don't have AV fistula in bone, not exactly Paget's disease, but Paget's disease-like condition, to make sure that there is no AV fistula anywhere in the body that is driving the systolic blood pressure. If the patient complains of palpitations, warmth, good appetite, but no weight gain, then I think it's easy to get a very cheap test, T3, T4, TSH. So basically what I would do in patients with significant systolic hypertension in the elderly is make sure that they should not have aortic regurg, but if they do, at least that is an explanation. Or just check T3, T4, TSH, but beyond that I would not do any extensive testing.
The mortality in a controlled hypertension at least is 1.5 to 2 times of a normotensive. What is the reason for it and what can be done to further minimize this?
Yeah, this is because typically most people are getting treated between the ages of 50, 60, and 70. So the treatment is begun because these are people who have come for health checkup, or they have some abnormal ECG, they have something creatinine, they have proteinuria, blood pressure is high. So when you treat them, you restore the BP as long as they don't have significant CKD. But the thing is, they had a duration of hypertension that is so long and so residual vascular damage. Just like recently, there was a paper on lipids. People who have prolonged hyperlipidemia, when you treat them, the benefits are not there because they have this legacy effect of chronic hyperlipidemia. So the reason why, despite so-called physical normalization of BP, you're not changing the physiology that much the longer the duration of hypertension. The studies like VALUE and CISTURE have suggested that if you bring the blood pressure down within 3 to 6 months, which is also a very casual way of saying, then obviously their prognosis is better than taking a longer period of time. So as much as possible, you should prolong normotension and not prolong hypertension. You should treat the moment you see the patient.
Increased sympathetic activity has been noted in the Indian subjects, the Indian heart study, and also in other groups. So if a patient is controlled, will you like to reduce heart rate also if it is elevated by drugs or only by lifestyle modification?
ECU, I mean, I'm not an expert in this. I don't know if Prakash is listening, but you, both of you, when you look at the heart rate in your patient with cardiovascular disease, That paper of the Indian heart study of reverse dipping and the lack of morning rise in BP, very unusual findings, contrary to what has been published all over the world. The morning, there is no morning rise, and there is a reverse dipping, very peculiar findings in the study that we make sure that we want to validate it in the future. But would you reduce the heart rate by itself? No study has shown. Of course, epidemiologically, studies have shown that the people who have lower heart rate, their survival is better. But whether pharmacological reduction in heart rate with beta blocker, ivabradine, in patients who don't have hypertension has not been shown, I don't think it is advocated.
Yeah, I agree with Venkat that I think we should not be using the heart rate reducing therapies. Well, okay, I can put the camera on 1 minute, but camera is not that critical. What was critical is my voice here. Okay, yeah, okay. So yes, Venkat, yeah, you make a very good point. I would not, in and of itself, use beta blocker or ivabradine. Definitely, I will not use. That really has never been shown to be cardioprotective in these settings. Beta blocker, perhaps in somebody who has hyperdynamic circulation, but many of these patients will have hypertension. Without that high blood pressure, I don't think there is any indication per se by itself. So I agree with you. And I think the high heart rate and of course this reverse kind of dipping, etc., may be indication of poor general health in overall. And that is an indicator of poor outcome.
Dr. Ram, another issue is, when do you advise statins in hypertensive patients?
When you advise statins in, first of all, indication for statin remains dyslipidemia, remains people at a high cardiovascular risk, even with normal lipids, etc. Hypertension by itself has not been, in any of the guidelines, has not been cited as a reason for using lipids, although studies have shown that patients who are on a combination of antihypertensive drugs and lipids, lipid-lowering therapy, their prognosis is better. So personally, I think people are at high risk for cardiovascular disease if they have blood pressure by itself, not hyperlipidemia, usually 45, 50 and above. They are probably better off with having a statin therapy with the hope that we're reducing vascular disease. There appears to be a 25 to 30% reduction, additional reduction in cardiovascular morbidity and mortality when the blood pressure is lowered along with low lipid lowering therapy in comparison to blood pressure lowering therapy itself. But the guidelines remain very vague on this. And people are worried about the cost because that's a social issue. But the cost of the disease is always much more than cost of prevention.
The issue is, when we see specimens of children with coarctation of aorta, there's extensive necrosis above. Most of these children do not have risk factors for atherosclerosis. So what do you think?
Coarctation typically,
Hypertension can per se produce atherosclerosis, or lipids, of course, are very important.
No, Prakash might want to comment on it. Coarctation in children and young in combination with congenital heart disease is a fibromuscular abnormality in the aortic matrix, that kind of a coarctation. And if the coarctation is not detected, which probably happens in a lot of people, then ultimately they do develop systemic atherosclerosis because of high levels of blood pressure. And the specimens, pathological specimens have shown significant atherosclerosis above the aortic coarctation. And experimentally also, when people do experiments by putting a ring, constricting ring about the aorta, there is atherosclerosis. So I don't think atherosclerosis is causing coarctation in young people. I think coarctation might cause atherosclerosis if it is not corrected, especially about the coarctation.
And should antihypertensive medication taken at night or morning, or it does not matter?
It probably does not, and this debate will go on because suddenly some study from Spain, some community study will say patients who take the medication at night did better than people in the morning. I'm specifically referring to the study, but all the clinical studies which are randomized control trials have used morning administration, except in patients with so-called resistant hypertension, however you want to define it, to me it does not matter. Then it does make sense to split the medicine, because I don't think there are medications in difficult hypertension that really can put the lid on blood pressure for 24 hours with once a day. You need to give them twice a day.
And then in hypertension, it is only the fall in blood pressure matters, or sometimes the agent is also more important?
I mean, this is a debate that goes on. Currently, if you look at all more recent guidelines, and recently there was a paper, 3.1 million adults in China, it's probably likely to be accepted. Looks like the blood pressure by itself, when it is lowered significantly and maintained that way, is better. And the agents are important in terms of comorbidities, especially CKD that Prakash mentioned, heart failure, etc. In that, I think whatever agents we like, we all have favorites, you can use it. But one should not lose sight of the fact that the blood pressure containment is very important.
Majority of strokes occurs in mild hypertension. What is the reason for this?
Same thing that I mentioned, because by the time we treat hypertension, many of them have established disease, and in fact, I'm amazed how much carotid Doppler is, I wouldn't say used, probably overused in our India. Many of them do have carotid disease, so it is just the duration of unknown, undiagnosed, untreated hypertension, or basically very casual treatment of hypertension. Very casual treatment of hypertension.
Well,
And
in addition, I think Dr. Manoria Venkat would agree that mild hypertension during office may not be as mild as we think. Again, I think it's important to really look at home blood pressure monitoring, or whatever the cuffless 24-hour blood pressure monitoring. The studies have been done that so-called mild hypertensives really are not so mild throughout the 24-hour period. It's the load on the vascular system throughout the 24-hour period that makes a difference. And of course, as Venkat mentioned already, the total duration makes it significant. Mild hypertension is ignored quite often. The people have had hypertension for a long period of time, and then they end up having the vascular remodeling.
what are your comments on the newer calcium channel blockers? They say Taxonel and T compared to the time-tested amlodipine. Will you use the new calcium channel blockers?
Right. I mean, newer calcium channel blocking drugs, or you want to call them more conveniently as Japanese calcium channel blocking drugs, because every new calcium channel blocking drug has been from Japan. Cilnidipine, nimodipine, any calcium channel blocking drug. Pharmacologically, there is no doubt that they do have pharmacological actions that differ from amlodipine pharmacologically. And that is the reason why they get that special category in pharmacopoeia, because they have to meet certain characteristics. Certainly, the newer calcium channel blocking drugs, by the way, effect on blood pressure is very similar as amlodipine. When you give the right dose, 24-hour BP, the effect on BP is very similar, which is pretty good because amlodipine is a good antihypertensive drug. But small studies, including in India, looking at ankle edema, they have shown that the newer calcium channel blocking drugs tend to cause lesser ankle edema. In small studies, 30 to 50 patients using Archimedes principle, putting the foot in the water and measuring the physical volume of it, they have shown the new calcium channel blocking drugs appear to cause less ankle edema. And then switching from amlodipine to newer calcium blocking drugs in patients with proteinuria disorders appears to at least reverse the proteinuria or does not make it progressive. So the effects on the ankle are very much effects that you see in the kidney, but because both are arterial, afferent and efferent arterial. Kidney and ankle are the same. So there are benefits of newer calcium blocking drugs on these parameters that are a problem with amlodipine. Efficacy wise, it is very similar, and there is no outcome study between the newer and older calcium blocking drugs on not only an outcome, also not on LVH or anything, but on proteinuria, there are different outcomes. Proteinuria, not prognosis of patients with proteinuria. That has not been shown.
What is the current status of renal sympathetic denervation? It is likely that it may bounce back.
I mean, this is an area of continued interest, and recently that registry has been published, the global registry of renal denervation. I think renal denervation will continue to be investigated for another 5 years. With now what they are doing now is, as you know, because you are more of an interventional person, now they are doing bilateral renal denervation and including the branches with the spiral catheter. So it is a circumferential denervation. And recently there was a study in the European Heart Journal where actually they showed that the renal nerves, most of the renal nerves appear to be most dense at the distal, at the hilum of the kidney. So it is possible the failure of the earlier studies is you did renal denervation most proximally and distally. And so anatomically looks like the recent study, there are nice pictures of that also, how dense it is at the hilum, at the distal. So what is happening now is the technology of ablation is getting better and better, more circumferential, more complete, guided by renal nerve anatomy, which is going to be a good way to do it. Now the question will be on the registry, of course, has shown it's very good, but the people who have done the registry are the same people who have done Simplicity 1 and 2. Nothing wrong with that. Very nice people, by the way, very good people, and non-randomized trials. So I can't tell right now. I think it does make sense to continue the research. The problem continues to be how to identify people who are likely to respond to renal denervation therapy. So far, no trial has shown renal denervation therapy has replaced the previous antihypertensive drug therapy. No study has shown. I know that in global studies, they say from 2.9 medications, it has come to 2.7. I don't know the difference between 2.7 and 2.9 in terms of medications in an individual.
The treatment of hypertension no doubt decreases morbidity and mortality, but does not decrease the number of hypertensive patients. So attention should be focused on primordial prevention so that we have less and less hypertensive patients in futures. Any data available on studies available on primordial prevention?
Yeah, studies with trophy has shown you can prevent hypertension, and a study in Brazil, South America, with diuretic clothalidone they used. In trophy they used candesartan. In prevent they used clothalidone. It prevented the progression of hypertension, and it prevented the development of left ventricular hypertrophy. What the problem will be public health policy. Will the governments and associations have the courage to start pharmacological treatment early on? That takes a lot of courage to do it. Until we come to that courage battlefield where courage takes over the fear, then it will be a problem. Yeah, it can be prevented. At least studies have shown it can be prevented.
If there are any other comments, Dr. Didwani or any other faculties?
No, in terms of the prevention of hypertension, First of all, I think the primordial prevention, just to make sure everybody understands, is to preventing the disease before its onset. That's the main thing. And I think in China, there are studies that by replacing the salt intake, right, by substituting the sodium to the potassium-rich salt, they were able to show that there was a substantial reduction. What they did was very unique. They took a village in northern part of China, and the entire village, half of the village, they gave the salt substitute. The other half, they continued as usual, and they showed that the people who got the potassium-enriched salt really had on an average about 2 to 3 millimeter lower systolic blood pressure. And that, to my mind, is a very, very unique finding. And that they calculated, of course, it's calculations, that if such can be attained in the population, in China alone, that can prevent 2 million deaths in a year or two. So I think, yes, there is a strong emphasis on primordial prevention, but very hard to attain.
I think with this, we finished the scientific session. Any comments from any other faculties?
No, I must congratulate you for putting this together in these difficult times, and really, hopefully, we can do the live meeting soon if the COVID ending. But clearly, this was a very good effort on your part. It takes a lot of energy and organization. So thanks again, and best wishes.
And I join Prakash. Actually, PC, I know that sometimes it's kind of, you feel embarrassed when somebody praises you on your face, but putting a program, the state of art, and for the audience who are in their comfort of their, they call that drawing rooms in India, in their comfort, what has been published in the last 5 years has been presented.
Yeah.
That means you don't have to worry that you did not read the journal. Most of us were unable to read the journals as it is. So this distillation that brings conferences, of at least the one that you organize, this distillation is a great substitute for them if they missed out on publications for the last 5 years, at least.
And actually, this may be the new norm, and we may be doing more of these in future rather than
often.
Yeah. So,
we need your cooperation.
Yeah, absolutely. But I think the motto for 2020 is to live through it. That's the main thing right now. Just be safe, be healthy, and be well overall. Thank you again very much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.